Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is John Schwartz, Chief Revenue Officer at HSBlox. We are going to be speaking today about how HSBlox enables social determinants of health risk stratification, care coordination, and permission data sharing through its digital health platform. Welcome, John, and thank you for joining us today.
Yes, thank you, David. Looking forward to your virtual hearth here and the dialogue. Always fun.
Hope it's not too warm, but we try to make it warm. So, John, could you give us a thumbnail sketch of HSBlox? I've given the headline, but can you fill that out a little bit more?
As you indicated, we are a technology platform company. We're really a company of problem solvers, and we leverage the platform to develop, bring to market, and enable clients with solutions to really deliver on the promise of value-based care. That being a relatively new concept, but within healthcare still being defined, but it really has more to do with the coordination of all of the stuff that's going on inside of a patient experience, and knowing that a lot of that is currently being done at scale in existing platforms that have been in the industry for a while. Coordinating all of that is not an easy task, and especially doing it at scale. So that's where we feel like we have an opportunity to make a difference.
So value-based care is something that we've been talking about in healthcare probably for at least a decade. So what's different now?
Well, I think what's different now is the payment models are starting to catch up with the actual concept itself. If you raise it up and look at the U.S., we're spending, I think the last number I saw was a little over $3 trillion on healthcare collectively, and we continue to lag in some of the more important measurements. It doesn't mean that we aren't doing, some of it well, but at the end of the day, we're spending an enormous amount of money, which also is time, which also is experience, which is, David answering the same questions at every stop instead of all of that information being asked once, packaged up and made available to every constituent that David is going to talk to. So I think the stakes have changed in terms of the amount of money that is going to be paid for the subpar results are now the question. Okay, and I need results if I'm going to pay. That, I think, really is somewhat the seminal flipping point. We're, the largest payer in the country, our government, is increasingly moving towards value-based payment types of models. And, historically, as I'm sure you've run into given your background, the commercial markets typically follow once that occurs. So the entire $3 trillion then becomes part of the scope, if you will.
Right. The scope of the spend, the size of the spend, the increasing budget for healthcare is certainly one component of all of this, and the importance for getting it right. And we're talking about not only the budget, but also the impact on people. I mean, the spend is enormous, and much of that spend, quote unquote, goes down the drain in terms of waste, fraud, and abuse. And I guess for purposes of this conversation, we can be talking about waste and how do we stem the tide of waste if we sort of convert payment systems to value-based care models. If we do that, maybe we can stem the tide of waste. But in order to do that, we are really looking at what? So you're focused on care coordination. You've talked about social determinants of health. What is it that you're service that your system is doing to plug the holes here?
Let's start with the topic of social determinants of health. Again, a concept that's been around, but has really never had the sort of visibility that it achieved in last year's pandemic. I worked with some very large health plans in the country at that point. And as the U.S. economy was grinding to a halt and all of us were trying to figure out, okay, how do we go from driving into an office to being completely virtual and still have jobs and responsibilities and so forth. And more importantly, revenue to pay expenses like benefits. And I was working with insurance carriers at that point who, were doing everything they could to keep people in their benefits. But then the concepts of furloughs and other things meant, okay, we've got to look beyond the traditional medical provider event-based system that we've all developed here and start to tap into the other resources that are available. And so community programs, community service organizations, things like Meals on Wheels, took on a very different visibility because it wasn't just poor elderly shut-ins that needed meals. It was other people that were suddenly, disadvantaged and had kids and families and so forth. So we were provided with a different lens with which to look at those types of resources. So now as we head, cross our fingers out of this pandemic and into returning to normalcy. And now what we're seeing in our pursuit of the market and some of our client base is that social determinants of health move beyond the natural that makes sense. Let's give people a list. They can go use them if they want, to finding a way to not only harness that, turn it into a network, but also figure out how to plug it into the scale that we currently have to deliver the healthcare that we have today to that many people. So the scale of the pipe that's there, how do you take a new process like this and plug it in? That's really where the industry is in that struggle today.
It's a challenge because, as you said, it's really we're talking about something that's different in kind, right? There's hospital admissions and drugs on the one hand. We know how to track those. We know how to order those. And there's food, housing, education, transportation on the other hand, which determines a much greater proportion of outcome and status. And the question is sort of how to integrate that. That's sort of a broad question. And I guess the question is for you, how do you draw a line around those challenges? What are the challenges that you identify and how can we solve them in terms of bridging the gap from the pure healthcare ecosystem to the broader ecosystem that involves social determinants?
It's a great question because that is a very meaty question. And by the way, I'm sure as you have had your travels in the healthcare industry, this is not an easy problem to solve. So it's not like somebody's been sitting on their hands, just not doing this. It's just it's a difficult problem to solve. How do you achieve scale on something that is new? And I frequently turn on podcasts when I'm road biking, and I was listening to one the other day that there was a statistic thrown out. And I have the truth in lending here. I have no idea if the accuracy. I haven't checked it, but the statement was: if you read a New York Times cover to cover, the new information included in that dwarfs actually the amount of new information that a person in the 16th century would have consumed in their entire lifetime. So whether that's true or directionally true, it's kind of the problem. The event-based system that we've got today is very good on the B2B side. So meaning we know how to, as you indicated, we know how to bill for it. We know how to order things. We know how to schedule people. We know how to follow up and so forth. But if you start to look at incorporating something new like social determinants of health with a entirely different network of providers, if you will, non-medical, but still providers, they're all at a very different place technology-wise than the rest of the industry. So you take, as an example, a person, say I'm an economically disadvantaged person, I'm living in a rural area that's a food desert, or at least to me is a food desert, and I'm diabetic. Well, I show up in an ER, that's an adverse event for someone who's responsible for paying for my health care. So they'd like me to be well managed. Well, our typical approach is, well, get me into an endocrinologist, one that's quality, get me a foot care exam, get me access to inexpensive insulin, and get me some education. All of those things are great, except I eat 3 meals a day at McDonald's. Why? Because it's 3 blocks from my house and I have no transportation to get anywhere else. So,
right, that's one of the perennial problems here. If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is John Schwartz at HSBlox. John, I talk about rural food deserts and their urban food deserts and areas of need as well. And I've been familiar with a program in inner city hospitals where basically there's someone at a desk in the emergency room who can, quote unquote, write a prescription for groceries, can write a prescription for a referral to a housing counselor. As you were starting to say, those parts of the quote unquote system are not really integrated or don't have the technological backbone to be integrated with the healthcare system. So is that what you're building? And are you working with healthcare providers, with payors? What's your point of entry into all of this?
Yeah, so I think I'd sum it all up with, this creates a lot of unstructured or need to digitize unstructured data. So if I'm that, food prescription and I take that to whomever is filling that out, they probably don't have an EDI billing system. They probably can do a PDF, maybe send an Excel file. The ability to efficiently deal with that and not just take it in as a blob sitting in a database so that you have it, but actually digitize it. So turn it into all of the information that is inside of it so that it can be used further down the road in granular parts of the transaction. That is how we are looking at this. It's more than just connecting the parties. It's actually enabling the parties, but doing it in such a way that lets it plug into the scale that's already there so that we can use the billing and the reporting and the EOBs and all of those things that are already there to incorporate social determinants of health as just another part of the benefit that's administered.
So again, where's your point of entry to the system? And are you surfacing recommendations to quote unquote prescribers or referrers, or how does this all work in practice? I'd love if you could get super concrete here.
Yeah, the entry point is, at this point, the person or the entity that's holding the risk. And in most cases, that is the payer. And as payers begin to organize a social determinants of health strategy to supplement either their Medicaid or Medicare Advantage markets, which are probably the most advanced in use of it at this point, we're finding and enabling really a number of starting points. So some payers, need a network, want that network to be custom developed and developed within certain geographies. for specific domains of SDoH, meaning, we want it for transportation and food, but not housing. Some payers already have developed a network or are leveraging someone else in the industry to provide that network. What they actually need is the ability to capture consent, the ability to digitize all of that and turn it into a scalable process. So we're doing really all parts of it. I would say our biggest strength and where we're delivering probably the most value at this point is the digitization of the unstructured data and building a consent process around the entire journey so that it not only streamlines the experience on behalf of the patient, but also streamlines and keeps informed all of the constituents along the way. Right.
So it's digitized. So is this another platform for someone to log into, or do you connect directly to, say, an EHR or to something else?
Yeah, we aren't another platform. We can be, but we typically don't want to be. We'll provide the workflow where it's required. But more importantly, what we're trying to do is fit inside of the current investments that have been made in this process and lift it up and make them all better. So we'll close some of the gaps, but do it with APIs and technology.
Right. In this year of the coronavirus, have you seen adoption of these systems increasing? We've all seen the need for these systems increasing, but I'm curious about whether the adoption curve has kept up and whether you see payer systems accounting for all of this and really building out and maturing the value-based payment models.
I would say the answer to your first question is a definite yes. The SDoH dialogue has gone from just that, from dialogue to action. I would describe the payer market as everybody is developing a plan. Some of the more cutting edge payers are not only developing a plan, but they're actually refining and making further investments in something they've already put in place. So the momentum around it has gotten off of we're just talking about it to we're actually putting energy and money towards it. The movement towards value-based care has also taken on, I think, a new energy, particularly although carve-out and capitation has been part of our healthcare system for a long time. There's been an emergence in the last 5 years, particularly around Medicare Advantage, of, I describe them as care coordination carve-out companies or risk-bearing entities where they are forming to approach a payer and say, give me all of the risk on that you have and the payment you're getting from the government on a particular set of zip codes. And I'll take that off your hands. I'll run it because I can run it better and I'll guarantee you a margin. So the concept of who is the payer has also begun to morph. And so, we don't see the traditional healthcare carrier as really the only point in the market that will need this sort of capability. Those companies that are carving out risk and taking upstream risk from government or from other carriers will also need this, and thereby that need and that avalanche will start to drive standards. It'll start to drive a lot of acceleration in the cooperation around it, which will raise the boats for everybody.
Right. Yeah, I'm thinking about ACOs. I'm thinking about ACOs both on the government side and the commercial payer side, and certainly a number of different companies that are accepting risk in some way in the way that you describe. And we're really in sort of this age of the payvider, I guess, sort of
Yeah, you're right.
payers are doing providery things and providers are doing payery things, and it's just a little weird.
Yeah, it's blurred for sure. Historically, there's a truism: if you don't measure something, you can't change it. There's an equally important adage that if you don't align what you're paying for something with the value that you expect, you're always going to overpay. So I think what we're seeing right now is a collective movement of the entire industry to start to rally around what's really important. And the consumer side of this is really driving a lot of the movement and the perspective of really needing to make it easy and less confusing for the consumer. I mean, if you think about your ability to buy a car compared to shopping for healthcare, that's a very simple analogy that everyone uses, right? I can go on the internet with my cup of coffee in the morning. By the time I'm done, I know what dealers in my area have what I want, what the dealer invoice is, and what the current deals are. I can't do that with healthcare. That's a simple example, but it's difficult to pull off. So if you start to think about expanding the types of providers, the financial relationships that have to be in place and enforced, the proof or validation that a service has been delivered, which is now required by the government to pay something, that isn't easy to capture. So we're at a point where technology has evolved to a point where we can start to solve some of this stuff and start to really solve it in quick ways. So we're going to have to unwind some biases that we have and really start to invest in connecting a lot of this stuff. And that's where we're really good at that. And we've solved problems not only in healthcare but in financial services. So we look at it as a not only a business opportunity, but an opportunity to do something larger and work inside of an industry that needs help and make a difference in people's lives.
So in addition to the track record that you've built, I hear you saying that there's more to come. And with that, I'd like to turn to our last question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or maybe expect to find has changed drastically?
Well, I think the single biggest change would be that, if you and I have this same conversation, if both of us view healthcare as another consumer decision in our daily life. So instead of it being a mystery and a black hole and a black box and not full of information, hard to figure out, that we're past all of that. And it's really more about quality and an exchange of information. That's where I hope we are in 5 years, because that's the sort of acceleration that I think we're on. And that'll manifest itself in our experience in healthcare becoming less and less complicated.
Well, nobody wants healthcare to become more complicated. So we'll certainly look forward to that.
Do that. I think that would be even better.
Yeah, that would be a pretty neat trick. Well, thank you, John. It's been a pleasure to speak with you.
Likewise.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.